Good afternoon, everyone, and welcome to our May Echo session. My name is Benita Arokiraj, and I serve as the Population Health Analyst and Echo Lead for the Constellation Regional Collaborative. I'm joined today by almost the whole team, I think, from CRC, who will be supporting the chat throughout the session. If this is your first time attending, please stay till the end to fill out our post-Echo survey to receive education credits. Thank you again for joining us today. We're excited to dive into today's discussion. Let's take a quick look at the agenda to get us started. We'll begin with a quick round of introductions to help ground us in who's in the virtual room. And we'll have a didactic presentation by Dr. Bridgette Schulman and a case presentation by Savannah Sanders from the Northeast Georgia Health System. After the presentations, we'll open up the floor for questions and discussion. We really encourage participation here. This is where the power of Echo comes in. It's all about peer learning and sharing across disciplines. And towards the end, we'll also share details about our next session in June, followed by a brief post-Echo session survey that helps us continue to improve and tailor these sessions to your needs. So we would love to hear from our Echo attendees. Please take a moment to introduce yourself in the chat by sharing your name, employer, organization, position, credentials. We'd love to see who's joining us today. And as responses come in through the chat, I would like my team to also introduce themselves. I already introduced myself. I am the Population Health Analyst and Echo Lead. And all the pictures you see, that's the entire Constellation Regional Collaborative team who help make Echo what it is. They support me with the planning and everything. Very grateful for their help. So Maxine, would you like to go next?
Sure. Thank you, Benita. Hi, everyone. My name is Maxine Arena. I'm the program manager for the Constellation Regional Collaborative. I will pass it over to Agner.
Good afternoon. Can you hear me, everyone? Now I'm
Yeah,
good.
a little bit.
Awesome. I think I fixed the problem. Hi, my name is Agner Munoz. I'm a certified community health worker and the community health specialist for Constellation Quality Health. I'm glad to be here. Thank all of you for joining us. And I will pass it to Shannon.
Hi, good afternoon, everybody. My name is Shannon Robinson. I'm the Quality Improvement Specialist here at Constellation Quality Health, and I am currently co-leading the Learning Collaborative with Sydney, and I will pass it over to her.
Hey everyone, I'm Sydney Fleming, the Outreach and Community Engagement Specialist. I'm also a community health worker, so nice to meet everyone. Glad to be here. Sylvia?
Good afternoon, everyone. I'm Sylvia Coleman. I'm a strategy consultant with the Constellation Regional Collaborative and delighted to be here with you this afternoon. And back to you, Benita.
Thank you. It's so nice to have the whole team here today. So very happy. We'll also like to introduce to you our incredible Echo Series subject matter experts who help guide the learning, share insights, and elevate community-informed solutions throughout the series. Because I'm sharing, I cannot see who's joined us today. So if you're on the call, I would love if you're able to come off mute and introduce yourselves to everyone.
Hello, everyone. My name is Emily Ridley. I serve as subject matter expert with Constellation Regional Collaborative. I'm a clinical pharmacist based out of an internal medicine residency clinic within Prisma Health in Columbia, South Carolina, where I've been for many, many years here. We serve primarily low-income urban population, but we also have many rural patients that we see within our clinic too. So I work a lot with our patients and helping improve hypertension and diabetes, which go hand in hand, it seems. But I've also worked extensively with quality improvement efforts with hypertension control across our health system and have served as a consultant with PAHO, with Hearts in the Americas. I'm looking forward to hearing the talk today. Thank you so much.
Thanks, Emily, for joining. What an excellent bio.
I don't see any of our other names, Benita.
All right, so I'll just introduce them briefly. So we have Dr. Jeffrey Bretler, a practicing physician with a lot of experience in chronic disease management. Honey Estrada, who's a community health worker, a very strong advocate for health equity, especially in North Carolina. Then we have Doctors Donald DePetty and Lackland, both of whom are nationally recognized leaders in hypertension and cardiovascular health research and policy. And we have Valerie Perez, who is a subject matter expert in unhoused populations. We're incredibly grateful for their ongoing contributions to the series and the broader work of our work with the Constellation Regional Collaborative. And now we would like to introduce our didactic presenter of the day. We have Dr. Bridgette Schulman, who is a nurse with over 22 years of experience in maternal health. She is the co-author and recipient of the HRSA Maternal Health Innovation grant named HOPE, which stands for Healthy Outcomes and Positive Experiences for Georgia Moms, Hope for Georgia Moms, and currently serves as Clinical Outreach Manager, where she works collaboratively with state, clinical, and community partners to execute and implement identified strategies for improving maternal health outcomes across the state of Georgia. She has a Master of Science in Nursing Education and a PhD in Nursing with a focus on interdisciplinary health. Additionally, she holds a certification in inpatient obstetrics and is a certified professional in patient safety. She's also strongly engaged in I don't know if there is a way to pronounce the acronym.
A1.
But A1? Okay, awesome. Where she is an obstetric patient safety program instructor trainer, was a contributing author to the second edition OPS-OB emergency workshops, and serves as a co-lead for the Northeast Georgia chapter. Dr. Schulman is honored to continue to bring her passion for patient safety, quality improvement, and ensuring equity is centered in maternal care to improve outcomes for all Georgia moms. I'd also like to go ahead and introduce our case presenter of the day. We have Savannah Sanders, who is a board-certified physician assistant with the Georgia Heart Institute. She specializes in women's heart health through the Women's Heart Center. Among Savannah's interests is screening pregnant and postpartum women for cardiovascular disease risk and ensuring that high-risk patients receive prompt follow-up care from a cardiologist. Savannah completed her professional education through the Philadelphia College of Osteopathic Medicine. Thank you both so much for joining us today. Feel free to add more to your introductions, and I will stop sharing so that you can get started with the presentation.
Bridgette, you're muted. There you go. Thank you.
There you go.
Can you see the slides? And I'm going to go in presenter mode.
I can see the slides.
Great. And now do you see it in presentation?
Yes.
Yes, ma'am.
Great. Well, thank you so much for that introduction, and thank you for allowing us some time today to talk a little bit about some things that are happening in Georgia. I'll talk a little bit about the Hope for Georgia Moms grant, and then we'll provide a case study with Savannah. So I don't think we could even begin to have this conversation until we talk about the current state of maternal health in the U.S. We know that there is a crisis. There are a few probably more well-known cases on this presentation, and I'd just like to take the opportunity to say some of their names. Anytime I have the opportunity to talk about maternal health or cardiovascular disease. Kira Johnson was a wife of Charles Johnson. She raced cars, spoke 4 languages, loved life, and unfortunately passed away following the birth of her second child. Dr. Shalon Irving worked at the CDC in Atlanta. She actually studied disparities in maternal health and also, unfortunately, lost her life after delivering her child. And then Tori Bowe was another high-profile case, Olympic medal-winning athlete, and unfortunately passed away in her home, likely to complications of preeclampsia. And so what we know about maternal mortality is in the United States, we know that Our mortality rates are higher than other comparable industrialized nations. And then when we know in Georgia, which is where we are from, Savannah and I, according to the 2020 to 2022 MMRC report, the Maternal Mortality Review Committee report, we had 141 maternal deaths during that 2-year period, giving us a mortality ratio, a pregnancy-related mortality ratio of 37.9 per 100,000 births. And what we see in the data is that cardiac conditions is a leading cause of pregnancy-related death in our state. And when the MMRC does their very in-depth investigation of every maternal death in our state, we recognize that 87% of the time that death could have been prevented had something different happened in the cascade of care with a mom. And then another really important thing to think about when we look at maternal mortality is the timing of death. And again, when we look from the 2020 to 2022 data, 71% of the pregnancy-related maternal deaths happened from day 1 to day 365. And for me, I've been in this space. I'm labor and delivery nurse by heart, by training, by passion, and moved more into quality improvement and education through the years that I've been in this area. But for me, for so long, I thought, 6 weeks, moms are good. Everything goes back to normal in 6 weeks. And if we didn't look at this data and we didn't use data to help us understand, we'd miss 30% of the maternal deaths in our state. You can see in this graph that from day 43 to 365 is when some of them are occurring. But also shows us there's a lot of opportunity, not just in the hospitals, to make sure that deliveries are safe and we're implementing the best evidence-based practice, which is where I've spent most of my career. But there's a huge connection to community and what happens to moms after they leave the hospital. Particularly in Georgia, there's a number of other factors that have to be considered when we look at access and equity. And if you look at the first map, of the red, everywhere you see red is a county that does not have an OB unit. And then in the second map on this slide, it shows the number of labor and delivery units that have closed from 2014 through September of 2025. And our Atlanta area, you can see, has a number of level 1, level 2, level 3 facilities. And that's not where they're closing, where there's abundance. We're closing in regions that are already, struggling to provide enough services and care. The good news is there's a response. There's a response at the federal level. HRSA has awarded the Maternal Health Innovation Grant to 42 states since 2019. And Georgia has received the award. It was technically awarded to the Northeast Georgia Health System, which is where I work. But the intention of the grant is to look at maternal health outcomes across the state of Georgia. And part of that grant includes 2 deliverables. One was to build a maternal health task force that should include stakeholders from all different areas and disciplines to work together to create a 5-year strategic plan. So those are the 2 biggest deliverables of this grant. So we have close to 60 members of our task force now. We really believe that our task force is evolving in that we never want to assume everyone is at the table. And we make sure that we try to make sure we've represented community members, community organizations, academia. We have clinicians, payers, and it's very important for us to also include people with lived experience. And so this is just a graphic of some of the members of our task force. And so when this task force got together, we do an in-person strategic planning session every year, and 5 focus areas came out that the team really believed needed to be addressed. And the first of those, the focus area, is maternal cardiac, and with the goal of advancing heart health awareness, screening, and care to protect the lives of moms. The second is advocacy and respectful care, to build a culture where moms' voices guide the decisions that shape their own care. The third focus area is postpartum care access, to build a seamless postpartum care system that supports mom for a full year, which we just kind of talked about the importance of that. Mental health is the fourth focus. Make mental health care easier to find, easier to reach, and easier to trust. And the fifth focus area, data, with the goal of making maternal health data more meaningful and shareable to inform decisions to improve the outcomes for our moms. And we are addressing these focus areas through three lenses, if you will. We have three subcommittees. One is more of a clinical and equitable experience lens. The second is community advocacy and respectful care. And then our final lens of this is the data. So why is CVD a leading cause of death? Or if we know that this is the leading cause of death, how does this continue to be, the front runner for this? And there's a few very distinct things that could be potentially, contributing to this. One is that, in a way, pregnancy itself is a stress test. There are many, many physiologic changes that happen in pregnancy. There is more blood volume, there's literal changes to the heart, cardiac output changes, your pulse rate changes. And generally speaking, women that are in the childbearing age are usually young, fairly healthy. And at different points, they might experience a little bit of shortness of breath or a little bit of swelling or edema. They might feel tired just because of the normal abnormals of pregnancy. And many of those symptoms are the very things that we need to look for if we're going to identify cardiac conditions. So there can be this area of, well, is it just because she's pregnant, or is this really something that we need to be watching for? Another thing that's important is ACOG does have a practice bulletin that says all pregnant and postpartum women should be screened for CVD. So I want to talk for a second, because I am the kind of person that really needs to understand the why of things. So I want to share with you the background of a CVD risk assessment that I'm going to spend probably the majority of the rest of the time talking about. And this came from the California Maternal Quality Care Collaborative, the CMQCC. And many years ago, they recognized that they were having a significant amount of maternal deaths specific to cardiac conditions. And they recognized they needed a tool to help them identify some signs and symptoms. So they took all of the information that they got from the maternal deaths that they had, and epidemiologists did what epidemiologists do really well, and they took all of these symptoms, vital signs, risk factors, and made them into a screening tool, and then took that and validated it in a number of settings, including California, New York, and North Carolina, and different levels of care and different populations. And so now this screening tool is the only validated tool for this population for CVD risk. And what's interesting is when they use this very tool on the pregnancy-related deaths that they had for cardiac, they recognized they would have been able to identify those patients 88% of the time, and possibly could have changed those outcomes. So this is the version of the CMQCC risk assessment that I just talked about. This is a version we created as a paper risk assessment. And you can see here on the left side of the tool in the blue, there are three sort of categories. There's symptoms, there's vital signs, and there's risk factors. The way a screen is positive is if they have one positive in each of the sections, so one positive symptom, one vital sign, and one risk factor, or a combination of any of those in those three categories. Another way that this screen can be positive is if they have any red flags. So you can see there's some symptom and vital sign red flag, one red flag, that is considered an at-risk screen. And then the same with the physical assessment. If there's crackles in the lungs or a loud murmur, either one of those makes it at risk and would warrant further evaluation. As we began to implement having our moms at our organization screened with this validated tool, we recognized that we really needed to integrate it into our EHR to make sure that this becomes, a standard process, didn't put too much burden on the staff that were completing it. And so this is an example how we took that CMQCC algorithm and integrated it into our EHR, which happened to be Epic. So I want to just kind of take you on the journey of Northeast Georgia Health System's journey of integrating the CVD risk assessment. And really, we made the decision to start on the inpatient unit. So in Georgia, many of our larger health systems have started screening, and some start in the outpatient setting and some start in the inpatient setting. And there isn't a wrong way to do it. The important thing is that we start screening our moms on a standardized basis. So in August, we actually launched a pilot just using a paper version, which I showed you earlier, in one of our smaller campuses. In December of 2023, we had it integrated into Epic. So 2 of our campuses, our larger campuses, level 3, and then our level 2. And then in June of 2024, our level 1 facility. So now all 3 of our facilities in our health system are screening our moms the day after delivery. And then in February of 2025, we went live in an ambulatory setting. And so now all of our moms get screened in the 2nd trimester and at their postpartum visit. And then another really important component is making sure that your emergency department is on board. And one of the very first changes that they made is instead of just asking, are you pregnant? They now ask, or have you been in 1 year? And that's really, really important so that we at least put that differential in our mind of, okay, this mom has been pregnant in the last year and I might need to pay attention differently. And then another thing that the ED did was to complete a learning module on cardiovascular risk that talks about signs and symptoms, different diagnosis, how to manage them on a very short level, and more about how the screening worked and about the resources available at our organization for referrals to the Women's Heart Center. And so as of December of 2025, from inception to now, we've screened 12,346 postpartum patients. We have 451 that have screened positive. And this was really important for us. We were the first hospital in Georgia to truly integrate this and standardize it. And we've been able to share our information with any health system that is interested or needs to learn more, because the first instinct is, there's no way we can do this. There's no way all moms, if you look at that list, all our moms will be pregnant. Will be positive, but in fact, they are not. Our positivity rate has remained around 3 to 4% the whole time. And so that is an important, just even proof of concept for people to consider starting to screen moms. And so of those 451, 353 followed up with a cardiology referral. So that's 87%. And then I also found it interesting that of those that did not screen positive, there was still 10% referred to cardiology. And that just shows us that there is increased awareness. And so even if they didn't screen positive, there may have been concerns by the provider that made them choose to give the referral. And then this is just to show what is causing the screens to be positive. So I told you the 4 different ways they could be positive, that yes in each of the 3 categories, 4 in any of those 3 categories, or if it was a red flag, or if it was the physical exam that was making them at risk. And this is just an infographic of the workflow at our organization. And so a mom that is pregnant or delivered will get the CVD screen. If it's at risk, then there is an automatic order panel that orders an NT-proBNP, an EKG, and a referral to the Women's Heart Center. And if they're not at risk, they'll just continue to have that standard care. And then once they get to the Women's Heart Center, they can do any additional testing they may need. Maybe they need an echo or a Holter monitor. And then we have partnerships. We have a pharmacist that works closely with Savannah's team, who is kind of the glue of this OB cardiac team and handles a lot of the referrals in partnership with her cardiology team. And then starting to address some of those modifiable risk factors, maybe managing medications, and then following them for that year, depending on when they were referred to the center. And then a couple other things I just want to share about really cool things happening in Georgia that I believe are very unique. Our state's really rallying around CVD risk assessment. First of all, our Georgia Perinatal Quality Collaborative is implementing the AIM cardiac conditions of obstetric care bundle. And so the delivering hospitals that are engaged with the GAP-QC are initiating a bundle around cardiac, which the CVD screening is part of that. And then another really amazing things is these are all of our, well, two to three of our residency programs, starting the year before last, all of the OB residency programs chose the CVD risk assessment to be their sort of quality improvement project and implemented the CVD screening. And then this last year, family medicine programs, so there's 15 family medicine programs in our state. They implemented and rallied around CVD risk assessment by launching a learning module, a 4-hour learning module that had a pre and post test and case studies and really explained how the CVD screening works, why it's important. And right now we're currently trying to engage our emergency residency programs. Another thing that happened in Georgia, Hope for Georgia Moms launched about a 3-month social media campaign directed at patients to really help educate them that, if you feel certain things or, you could have cardiac risk and talk to your doctor. And sometimes pregnancy is the first time that cardiac risk is recognized. So that had over 2 million impressions. And then another really important part of this is the importance of not just the clinical people, not just the hospitals or physicians' offices doing this, but we're now seeing people screening in our community. And I really wanted to share this. One of the residency coordinators trained a set of doulas. Wellstar, which is one of the health systems here in Georgia, integrated doulas into their staff, which was amazing enough. But then they train them to do the CVD risk assessment at their postpartum visits, and then kind of train them on what would be concerning. And so they're screening moms. So the more eyes we have on moms that can recognize if we start seeing these early symptoms, the better. And then in Georgia, we also have a state home visiting program who are also including screening and providing education to patients. The GAP-QC, which I told you is our state perinatal quality collaborative, have created a lot of tools and resources. And one of those tools came out of the doula screening. And one of their concerns is, if I'm screening, what do I do if the patient is positive? And so they created this emergency heart card to give a mom if there is concerns. And you can see on the front, it says, this is a check my heart card. And on the back, it's specifically meant for the provider of the emergency department or urgent care they're walking into. And it's saying, please consider the following tests: the EKG, chest x-ray, BNP, and troponin levels, which comes directly from an algorithm that I'll share with you in a minute. Some other resources that we have, again, you can see on the left, the GAP-QC took that CM-QCC algorithm and made it badge buddy. So one is one side and the other is on the other side. So those are your red flags on one side, and then those combinations of things that have to make it a positive screen. And then you see the paper one that we created, which was the first pilot of our health system. The other thing is patient education materials. So educating moms, which we use the acronym PEACH, which is appropriate for our Georgia state. And so really heightening in on what they might experience if they have cardiac risk. So all of our moms that screen positive will receive the PEACH card and explain that they should be watching for these things. And then GAP-QC also created tools for providers. And so you can see there's this cardio-OB reference guide that has a number of cardiac conditions and some recommendations on how to manage it. And maybe if this is a small rural hospital, things they can do until they can get that mom to a higher level of care, or maybe somewhere that has obstetric services. And then they actually created an app. It is only for iPhones, but that app is what's on the fourfold. And then this is not, I always say this is not an OBGYN project. We can do a lot of things. When we did our hemorrhage AIM bundle or a hypertension. We really kind of did it in our own silo, and we did our thing with our group. But if we're really going to move the needle on cardiac conditions, it's going to take a whole village, and emergency room is a huge piece to this. So this is an example of an algorithm that's approved by ACOG, you can see, and all the emergency medicine professional organizations. And it's another iteration of the CMQCC algorithm that kind of shows them, hey, if there are these things present, here are the things you need to do: the EKG, the BMP, the chest X-ray, and troponin. And that's why we put it on that mommy heart card as well. And then again, another thing the GAP-QC created is the importance of asking that question. Not only are you pregnant currently, but have you been in the last year? Because it's important for me to be able to care for you. So these posters were created by the GAP-QC, and they can be hung in offices, urgent care facilities, emergency departments to, again, increase that awareness. And this is something I also wanted to share. It's kind of a statewide collaborative, but the importance of having access to mental health. And even more important is some of our prescribing providers having the ability to access a consult with a psychiatric professional. So this is another a HOPE initiative, a little off base, but we know there's a lot of overlap with mental health, cardiac, and stress and things like that. So I did want to share this. This is a state-funded psychiatric network that does free consults to any prescribing provider that has a patient that's either pregnant or up to 1 year postpartum. So with that, I will pause. And Savannah, if you would like to jump in and do the case study.
Absolutely. So can you hear me first off? Because I got you in two different places. So if I'm not looking at you, it's because I'm looking at my other screen. So my name is Savannah. I am the physician assistant with the Women's Heart Center here at Northeast Georgia, also known as Georgia Heart Institute. I am the coordination of care director, if you will, between OB and cardiology. And I just wanted to share a case study of a patient who actually came through our office, was screened, and just her story. So she was a 30-year-old female. She was African American. It was her first pregnancy. She definitely was overweight. The first time that we saw her was at 22 weeks, which is about when we're screening in the offices. She was complaining of shortness of breath with activity and all of the fun things. So her past medical history included having high blood pressure before she became pregnant. She has prediabetes. She had asthma. She's a smoker. At the office, her blood pressure looked good, 126/60. Heart rate was well controlled at 91. And when she came to me, she was already on some blood pressure medication because she has that history. She was taking her prenatal, her baby aspirin for that preeclampsia prevention, since she does have chronic hypertension. She was on labetalol 200 milligrams twice daily and nifedipine XL 60 milligrams once daily. And of course, she has asthma, so she had an albuterol inhaler as needed. So because we have this risk assessment, we're able to take her information and plug it into her risk assessment. So if you want to click, I'll go through the role with you. So she is African American. Now we know that ethnicity alone is not what makes someone at risk. There is just thought to be some implicit bias around being African American. So we know it's not necessarily the genes, but rather just some implicit bias. Next, her BMI was greater than 35. She was experiencing shortness of breath with activity. She had history of high blood pressure before she became pregnant, and she also is a smoker. So because of those things, that put her at a higher risk. That's okay. That put her at a higher risk, screened positive, which meant that she got a referral to cardiology, which in my world is me. And she got NT-proBNP EKG. So NT-proBNP came back normal. It was about 100, which is something that we're not super concerned about. Her EKG looked great. Because she was experiencing shortness of breath, African American, all these other risk factors, we did go ahead and get an echo just to make sure that everything was okay. We got the echo. It was beautiful. Her ejection fraction was 60 to 65%, which is perfection. She ultimately came back and saw us after delivery. She was like, oh my goodness, pregnancy just kicked my butt. I feel so much better. Her blood pressure was well controlled. Her shortness of breath with activity had went away. Because of those things, normal testing, feeling better, blood pressure under control, I encouraged her, hey, you just continue to follow with your GYN or your PCP annually for monitoring of your blood pressure and GYN concerns, and I'm going to give you a peach card. And explained that if you were to experience palpitations, swelling, abnormal breathing, chest pain, worsening high blood pressure, you should get evaluated either by calling our office or going to the ER. Ultimately, 2 weeks later, which put her at 8 weeks postpartum, she was having worsening shortness of breath. She has asthma. She thought, hey, I'm having worsening asthma. I'm using my inhaler. It's not getting better. But I remember she said if I was having worsening shortness of breath, I needed to get it evaluated. So she went to the ER. They had, she was specifically saying she had difficulty when lying flat. She was having worsening shortness of breath, and she felt like she was gaining weight even though she was postpartum. Blood pressure was high, heart rate was high, all the fun things. So when the ER were to do this risk assessment for her, of course, we already knew that she was at risk, but now we have those red flag findings. She was having difficulty breathing when she was lying down, and her heart rate was also greater than 120. So in the ER, they ultimately repeated some of the things that we had done. They had repeated a NT-proBNP, which had increased. They did do a chest x-ray because she was short of breath and it looked okay. They did go ahead and get a troponin, which was high. So between the high NT-proBNP and high troponin, they decided to go ahead and get an echo. That echo confirmed that she did have postpartum cardiomyopathy, and her ejection fraction was 21%. They did go ahead and get a cardiac MRI to make sure there wasn't any other possible etiology or possible cause of that heart failure, which of course confirmed that she did have heart failure. So patient is still a part of our care after getting stable in the ER. She was able to come to our office. We were able to get her on GDMT, or goal-directed medical therapy, which is how you treat all heart failure patients. We got her on Lasix to make sure she's not volume overloaded. We got her on metoprolol. We got her on Entresto, spirulactone, and Farxiga. And again, that is what we call GDMT, or the goal-directed therapy. As of her most recent echo, which was like, I don't know, 2 weeks ago, her ejection fraction had significantly improved, and we are back up to 50 to 55%. Part of the education that we've been providing this patient is just emphasizing that the medication she is currently on is not safe in pregnancy. So she does not need to be considering a future pregnancy right now while she's on these medications, and that she needs to be on birth control. Also, we had a conversation with this patient about future pregnancy because this is her first. She had never thought, she just wanted one. And she actually does want to, so we're working about what we're going to do about that. But just so that you're aware of what we call the MHU categories. For a patient who has previous peripartum or postpartum cardiomyopathy, but they have full recovery of their ejection fraction, it does not mean that they cannot have a future pregnancy. It just means it's going to be high risk, and that she's going to need to be watched super closely, at least monthly or bi-monthly, by a level 3 facility, for delivery. If she does not have fully recovered ejection fraction, it is considered MHU category 4, meaning extremely high risk. And there should even be conversation between, whoever it may be, but cardiology, OB, maternal fetal medicine, what have you, about possible termination of the pregnancy if she were to become pregnant, because it is so high risk. But that's why we want birth control, so we can avoid that conversation. So this is an example of a patient that we have seen in our office, and that is just a case of how we see things. I do have a video here of actually patients who have also been screened with this CVD and their experience on how they thought it went and how it influenced their care here. So we'll watch this video.
My husband and I are both educators, and we've been married a few years, and we decided, oh, we're going to try to have a baby. So we started trying, we got pregnant, we were so excited, and we went for our first ultrasound, and we found out it was triplets. We got to Friday, and they maxed me out on labetalol, they maxed me out on hydrazoline, they could not control my blood pressure, and I just knew it was go time. So we go in, they get the babies out, I start feeling like I'm gonna pass out. I didn't know it at the time, but I had had a severe hemorrhage. And luckily, before I had the boys, they had already done the screener on me, the cardiology screener. So they had done an EKG, they were scheduling an echo for me. Cardiology was already following me. I was in the hospital several days. My blood pressure continued to be really, really high. And so I went home on a maxed out dosage of labetalol. But then 2 days after coming home, I was back in the ER for a third admittance for high blood pressure, and cardiology was right there. They had already been tracking me. They knew who I was. They were ready, and they started making adjustments to that medicine. They got things adjusted, sent me back home with a follow-up scheduled for the very next week. So I came back in for that, and then it was amazing because I was on 3 different medicines at one time. But the maternal cardiac program, they were calling me every week to check in on my numbers, to adjust my medicine, to try to wean me off as they could on the blood pressure. And then when I had issues, I was able to call them. Even as far out as 6 months postpartum, I had an issue with a little palpitation. I was at work, I got dizzy, and I was able to call Savannah right then and there while I was at work, tell her my symptoms, make an appointment. I went in to see her immediately, got another EKG, ended up with a heart monitor, but I had that connection to that program, so I knew what to do when symptoms arose. I had somebody I could reach out to.
I wish I could say that my journey to get pregnant was something really exciting the entire time. I wish I had that story. That was gonna be a bomb. So I ended up delivering at 26 in 5 days, but the first sign happened around 21 weeks or so. Up to that point, I had a great pregnancy. Maybe a little nausea, a lot of cravings, but great pregnancy. And one Sunday morning, I woke up, I had a headache. I wasn't feeling the greatest, but there was some other stuff going on, just normal life stressors, and I just kind of chalked it up to that. But it happened overnight, and it was very scary. In my back of my mind, I kept telling myself, everything's fine, everything's fine. My background is emergency department. I've seen a lot of very sick people. So when I compare someone being sick, I compare it to the worst thing that I've ever seen. So I definitely was downplaying all of my symptoms. There was a reason for everything that I felt, for my headache, for my body feeling so tired, for my legs swelling, and I was pregnant. So on top of that, you have all of your normal symptoms of being pregnant, but then your life that just kind of causes you to also have these other symptoms. And so I just kind of downplayed everything. It definitely was that first admission when I was kind of laying on the bed, and all of a sudden I have the perinatalogist walking in, I have the OBGYN walking in, and I have now the cardiologist with a PA and the pharmacist. entourage of people just walking into this room for you because they think something's wrong with you. And definitely in that moment, I started to take things a little more serious, where I'm like, why are you here? And it's because they did the CVD risk assessment. Somebody saw something in me that I didn't see for myself. So somebody advocated for me when I didn't think I needed to advocate for myself.
Don't assume the symptoms are just normal. Even if it sounds like typical, the screener is so fast, it doesn't take much time. Screen them, see if there's any red flags flying up, because it could save somebody's life. Speak up if you feel like something's not right. Even if they're saying it's normal, this is what typically happens, you know your body, and you know if something's just not right, speak up, be an advocate, keep talking until somebody listens.
I hope that the CVD risk assessment is implemented to more than just the hospital where I was at. I hope it's taken and put into practice everywhere. And I hope that when nurses and staff look at this assessment, they see it as more than just a checklist, as more than just a flow sheet or a BPA that's flashing in front of you. I hope that when they see that, they see my face. They see the pregnant person that's sitting in front of them with their baby or babies that are coming, that they are saving a life, and they are advocating sometimes for somebody who's too stubborn to advocate for themselves because they're so used to taking care of others.
All right. So to wrap up, we hope that by the end of this presentation, a couple of things that we really hope stick with you is that for some moms or for some women, the very first presentation of cardiovascular risk or disease may be during their pregnancy or early postpartum. Take patients' complaints seriously. CVD maternal death can be prevented with earlier recognition, referral, diagnosis, and treatment, and screening all women who are pregnant and up to 1 year postpartum can help with that earlier identification. So shameless plug, we do have a website, social media, if you're interested more about what's going on with Hope for Georgia Moms, and this is our team. So with that, I would love to open it up for questions.
I don't have a question. I just have a comment. Just thank you for the work that you do. I wish that this was implemented across the country. I'm in Alabama. Had my own situation with my pregnancy, and I wish that I would have been taken seriously. Luckily, I work with hypertension knowledge, so I was able to advocate for myself, but that's not the case for a lot of people. So thank you.
You're welcome.
I would like to echo what Sydney said. I'm in North Carolina and I'm a fellow nurse. And this hit home for me with my, I have four-legged kids, and my Doodles trainer and our amazing sitter had her second baby in February. And she was similar to the first case that was described, except a bit older, 36. And she had problems in her first pregnancy. She was already high risk. And I'll make this short, but I will tell you, it was so frustrating. Her mother is an OBGYN nurse practitioner and moved down from Kentucky to support her, and was actually living in, and she was only home for 3 days and right back in the hospital in postpartum preeclampsia. And it was very scary. And she's been in and out of the hospital a number of times finally got referred to a cardiologist that specializes in maternal health. And it took a month to get in with. She just got in with her like a couple of weeks ago, and then it took a good while to get the echo. And of course, by then her blood pressure is continuing to be out of control, severe swelling to the point she couldn't get her shoes on, that like terrible symptoms, and some fortunately, minor damage already to her heart. But I'm like, okay, she has a village. She has a mother who's an OBGYN nurse practitioner living in. She has me. We're all advocating. It's like, come on. And she's in and out of a women's hospital, going in and out of the ED. So thank you, thank you, thank you for what you're doing. And the advocacy piece is, it does save lives, because what I kept saying to them is, do not let them send you home again.
Right.
Like, pitch a fit, do what you need to do. Don't let them send you home again, because this is life-threatening. And I will definitely be sharing the slides in this webinar and the notes that I took with them, because the grandmother is in the system here now. She has moved here. She is working in the system and can, I think, really make a difference. And I'll be sharing all of this. So thank you, thank you.
Awesome. I will say all the resources that are in there can also be downloaded from the GAP-QC website under cardiac and resources. And they do let you co-brand and do different things. So, and if anybody wants to reach out. And then I see a comment in the chat. Do you have cardiologists that are maternal health specialists? And what is the wait time to get a patient seen who has screened positive? And Savannah, do you want to answer that?
Yeah, absolutely. So again, I'm the physician assistant, and oh, sorry. There's a delay here. Sorry. So I'm the physician assistant, and I do have a supervising physician. Her name is Dr. Laura DeVoki, and she is our director of the Women's Heart Center. Because not all of our patients who screen positive actually have cardiac issues, the way our workflow is that if a patient screens positive on the outpatient setting, they will be sent to my office, and I will be their first point of contact. I will do their initial workup. I'll get their NT-proBNP, EKG, echoes, heart monitors, whatever it is that we feel like they need to be. And then we will escalate that to physician care if something comes back abnormal or concerning. Of course, if there's something abnormal, concerning, immediately, I'm able to contact her same day. As far as that time lapse, if a patient is screened outpatient, they can usually get in my office within a week or two. Occasionally, there's, times where patients need like stat referrals, but don't quite feel like they need to go to the ER. I'm often able to get them in same day or next day, just because that's all I see is pregnant postpartum patients. So we try to keep my schedule open, available for those individuals. If a patient is screened in the hospital and they are positive, I actually will go over and see patients in the hospital as well. We have a cardiologist available at our delivering hospitals 24/7. So even if I was not available or not there, we do have physicians who will go and care for that patient, talk to that patient, evaluate that patient, and then they'll get a follow-up with me in the office. Hope that answered your question.
I do see in the comment about the screener in other languages, and right now, or the resources. So right now, the educational resources are available in Spanish, like the Peach Card, but no other languages right now, and not in anything else. That's on the GAP-QC website. Anything else? So many of the partners are community-based organization. What other recommendations would you make for organizations wanting to help in this arena without medical training? And I think that's what was so I think to me, because I am clinical, when they trained the doulas and the home visitors, sometimes it's a community health worker that goes in the home visiting service. Sometimes it's a nurse, depending on what area they are in the process of bringing them on. But they can certainly look at the criteria on the screening tool and at least let the patient know when she has enough combination of things that would be concerning so she can advocate for herself. Also, the heart card, the mommy emergency heart card, helps give her the language to say, hey, something's concerning. And on the other side, it says, consider running these labs on me because someone has used a screener. So we can certainly share the paper CVD risk assessment. And there's actually a video that the OB resident program director had created to train the doulas. So that could maybe translate, and I can certainly get that to you as well.
I'll say my favorite resource, depending on like what it is that you're trying to do and trying to accomplish. I love the Peach Card. Ultimately, the Peach Card is intended to be for patients who have screened positive, but not necessarily. If the patient is having palpitations or swelling, and it's kind of written in layman's terms, if they're having chest pain, high blood pressure, it does say, hey, make sure you reach out to somebody. So even if it's reaching out to a OB or a PCP, or maybe they do have a cardiologist, that Peach Card can be very helpful. So even if you just had it sitting on a waiting room somewhere, or you had it available for someone, it's just a good resource of like, hey, if you're having some of these things, it's always worth further discussion with someone.
And I loved what I think it was Sylvia was saying, is just be encouraging to them that they can continue to speak up. There is nobody that knows your body. Doctors are very smart, nurses are very smart, but nobody knows your body like you do. So sometimes you have to continue to use your advocacy and your voice when you really truly believe something isn't right.
We're at time, so I would like to kind of just like summarize everyone's thoughts and be this was just so inspiring to hear. We're very grateful that we had we were able to listen to this initiative and just see the adoption, the things that have come out of it. And thank you for the work that you're doing. I know like pregnancy can be such a long and tiring process, thinking about all the different changes that are happening to you, advocating for yourself, but then to also have a team that's advocating for your health, especially for such a common issue, right? Especially in Georgia, it's so important and can be an incredible motivator to moms as well. So thank you both so much. Thank you to the team for doing this work. And I can only hope that, there's like a bigger widespread adoption of this risk assessment, because it is that important. Yeah, so thank you both for your time today. I'm sure, we're going to carry these stories with us, and there were a lot of incredible resources shared. So I will also try to combine all of that and send that out in an email today.
Okay.
Yeah.
And if anybody wants to reach out to, I'm happy to ever connect, or if you connect with a clinical site that is interested, always available to help in any way I can. So thank you all so much for your time and for listening to the presentation.
Thank you. And thank you, Savannah. And just a side note, for post-echo session survey, I dropped the link in the chat. I'll also send an email to everyone who attended today. I think a few people have dropped, but that will help you receive your certificates and education credits for your participation. So thank you everyone for joining us today.
Yes. Thanks.
Thank you.